Welcome, everybody. You are joining Silver Hill Hospital's Grand Rounds program. Great to see you, and I'm going to wait for a moment for people to join. All right. Again, welcome, everybody. Thank you all for joining us. My name is Jeff Katzman. I'm the Director of Education here at Silver Hill Hospital, and we are absolutely delighted to have you join us, where we're really privileged to welcome Dr. Elaine Alpert, who will be presenting on the topic of intimate partner violence, inquiry, evaluation, and response in the clinical setting. I will have the pleasure of introducing her in just a moment. First, a little housekeeping to start. Our next grand rounds will be on February 14th, and that will be with someone I know very well, Dr. Joanna Katzman, and she will be speaking to us on the topic I know it's quite important, the epidemic of gun violence in the United States and how we health professionals can help to make a difference. Back to today's lecture. Your questions remain an important part of our grand rounds. I will moderate a Q&A discussion with Dr. Alpert at the end of her lecture. This is a great opportunity to put forward questions and comments for Dr. Alpert, which you can submit at any time during the lecture by using the Q&A box. If you wish to receive CME or CEU credits, please just complete the evaluation survey that will automatically show in the browser when we end the webinar. We will also email a copy of the survey to today's participants. Finally, disclosures. No planners of this activity have indicated a relevant financial relationship with an ACCME-defined ineligible company whose primary business is producing, marketing, selling, reselling, or distributing healthcare products used by or on patients. And now, it is my absolute pleasure and honor to introduce our guest speaker today, Dr. Elaine Alpert. So I met Dr. Alpert when I sent a cold call email asking would she please be willing to join us here at Grand Rounds at Silver Hill. There was just such an interest in hearing an expert speak to us about intimate partner violence, and I had read and known her to be just that person. And I am so grateful that the email came back, said, yes, absolutely, I would be delighted. And now our big day is here, and I'm so happy to be with you, Elaine, and to learn some more from you. I've had the pleasure of working with Dr. Alpert in a violence prevention video-based program through our Silver Hill Academy that we call SHARE, in collaboration with Project ECHO for 8 weeks. And we'll have another one of those programs coming up for everyone who's interested in toward the end of March and early April. I have learned so much from Dr. Alpert through that program, and I'm excited to, Elaine, to hear from you again. Dr. Alpert is trained in internal medicine and public health and is an internationally renowned clinical educator, scholar, and consultant in family violence, sexual assault, and human trafficking. Her expertise spans clinical care, prevention-focused public health, and medical education, with a focus on curriculum design, communication skills, interprofessional education, and distance learning. Since 2009, Dr. Alpert has been affiliated with the University of British Columbia in Vancouver, where she created and taught courses about violence across the lifespan and about intervention planning to improve public health. She developed the UBC Interpersonal Violence Prevention Program and launched a web-based violence intervention and prevention connector. Currently, she teaches communication skills and sensitive interviewing practices, including about intimate partner violence, in UBC's medical school. Dr. Alpert's approach to teaching, research, and consulting champions collaborative working relationships among diverse stakeholders, including public officials, non-government organizational staff, scholars, educators, administrators, clergy, caseworkers, advocates, representatives of community-based organizations, and survivors through a trauma-informed, resiliency-focused framework. And I will tell you, just as we were in the green room chatting a little bit, and I said, how you feel about talking to a couple hundred people across the country, and she says, well, I get to talk on the Today Show long ago to over 1 million. So she's an expert at talking to a large audience in this format. So thank you, Dr. Alpert, for being with us, for your wisdom, for really your advocacy and how many lives you've affected, I think, through direct work and through training and through all the public health work that you've done. So, and thank you so much for being with us today.
Thank you so much for that gracious introduction. The Today Show audience was actually 130 million, and I found that out moments before we went live. So that was my jump in the deep end and
Wow.
and see what you can do. So it is my honor to be here, and I am here on the shoulders of some amazing inspirational role models, and I want to call one out who I believe is on this webinar as a participant. Her name is Dr. Ann Flitcraft. She was one of my two mentors early in my career, and I would like to throw a lot of thanks, gratitude, and admiration for her, and also for Sarah Buell, a lawyer who basically started this field in the field of law. So I don't come to this work alone. I also have learned almost everything I know from advocates and survivors. And there are at least two people from our regional domestic violence crisis center here also as participants. And so I will speak to that in a little bit. On this first slide, you will see my email address. It's also on the last slide. So please feel free, if you have questions that arise that are not addressed today, to please feel free to reach out and email me, and I will get back to you. And if I don't, just email me again, because sometimes my inbox gets flooded. I also want to make sure that you can access the local resources and the state and national resources that are available, because that is a crucial part of the work that we do. So with that in mind, I am going to try and advance my slides, which of course worked perfectly before and are not working now. So I am going to try to do something to make that happen.
Dr. Alpert, do you want to try your arrow keys?
The arrow key is now not working.
Oh.
Everything that worked before is not working now. This always happens, doesn't it? Even when you try it before.
Live in the moment, always.
Live in the moment always does that. Isn't that interesting? It just does not work at the moment. Nothing is advancing. There we go. Okay, it woke up. I have no disclosures. And here are our objectives for today. By the end of this presentation, my hope is that all participants will be able to describe basics around intimate partner violence, including incidence, prevalence, spectrum, dynamics, and clinical manifestations. We'll be able to explain the principles of trauma-informed care, which guides all of our work, and also discuss ways to inquire about and respond to disclosures that are identified in the healthcare setting. So everybody uses a definition to frame what they're talking about, and there is no definition that comes from on high. I am using this definition to talk about intimate partner violence, and others use slightly different definitions, but this is basically kind of a mid-road explanation of what we're talking about. It's a pattern of intentional coercive behaviors used by adults or adolescents against current or former dating or intimate partners. Let's unpack that just momentarily. This is not just one event, it's a pattern of behaviors. So if somebody is in a coercive relationship, it is the entire relationship that's coercive, not just the individual incidents that happen that somebody may report. We're also talking about both current or former dating or intimate partners. And I would like to add that especially in adolescent settings, we can be talking about people who are not dating, who may never have been dating, who may never have really met. There's a lot of texting and I'm with you and you're with me and you're not with that one. And so the whole field of adolescent relationship violence expands our conception of the traditional person who's dating or person who's married in in an intimate relationship. So really the definition is quite broad, and we see this in every clinical setting, in every specialty, everywhere. Everywhere. There are no exceptions. The spectrum is broad, including threats and acts of intimidation, social control and physical isolation, attacks or threats to property, pets, keepsakes, economic control, emotional degradation, the use and manipulation of children, sexual violence, reproductive coercion, spiritual abuse, and last, physical violence. I put physical violence last, not only because it's not as common as most of these other aspects of the spectrum of intimate partner violence, but also because when we think about it, we think about basically a woman with a black eye. And that we see, but we don't see that often. And we see all of these things much more commonly. And I'd like to point out that many of these acts that we see are illegal. They may be criminal. Some of them, physical violence for sure, sexual violence for sure, but others are actually not illegal. So they will never come to the attention of law enforcement. That means that those of us in healthcare are very often the first and sometimes only people who those experiencing violence and abuse and coercion in relationships will see and will trust. That makes our role all that more important. There are asterisks next to sexual violence, reproduction, coercion, and spiritual abuse, because those are such larger topics that I wanted to give each of them their own slide. So in terms of sexual violence, we're not talking just about sexual assault. We're talking also about interfering with birth control methods, including preventing the use of contraception or forcing the use of contraception. We're talking about sabotaging condoms or refusing to use condoms. We're talking about controlling pregnancy outcomes, and there are a number of aspects of that you can read on your own. So when we're asking about sexual violence or reproductive coercion, which we'll get to later, we need to ask about a number of these things and be open-minded in the kinds of questions that we ask. In terms of spiritual abuse, I learned a tremendous amount from Reverend Al Miles, who is, I believe he's retired now, the chaplain at Queen's Hospital in Honolulu. And he and I came together in a project to develop guidelines for Christian clergy in Chicago. And there's a publication it now shows its age, but I'd be happy to share that with anybody interested. But part of the components of spiritual abuse include preventing participation in an important or sustaining religious practice, requiring participation in religious practices when the person really doesn't want to, including exaggerating or degrading practices, those that disrespect or demean self-worth, restricting access to clergy or spiritual figures, and taking scripture and basically turning it into disinformation, misquoting or misusing scripture to frighten somebody, to force them into compliance, to assert privilege or dominance. And those of us who studied scripture know that it is so broad and so open to interpretation that it is possible to find passages or statements that justify whatever you're trying to prove. And so scripture is often used as a tool of control and intimidation. So why is this different from other types of violence? Violence is bad all the time. And we think a lot about what to do to prevent getting mugged, prevent a home invasion. But why is this different? Why does this have an impact that lasts longer than whatever a discrete other incident is? Well, think of it this way. There's an ongoing, evolving relationship with the person who is coercive to you. Most often, there's an emotional attachment to the perpetrator, even when the violence is ongoing. Very often the survivor is economically dependent on the perpetrator. And I will show you and tell you the story of a survivor who was a professional, a colleague, who absolutely had no control over even $1 of their finances. The survivor may share children, friends, or social or spiritual network with the abuser, especially in sexual minority relationships, LGBTQ. And in Canada, we also include two-spirited, which is an indigenous conception of gender. But if you come from a smaller community, immigrant community or a sexual minority, it's a small world there, and everybody knows everybody else. And so if you want to take action, you're really leaving your whole community. Okay. There's a continuum of coercion that I mentioned before, not just isolated incidents with everything fine in between, but the coercive part is really continuous and quite dynamic. Societal messages are very, very confusing. Very often popular songs. I keep thinking of the song Sting, from Sting, I'll be watching you. Every move you make, every step you take, every breath you make, I'll be watching you. So there are societal messages that we repeat in our heads and become earworms at night because they're popular songs. And they perpetuate messages of control. Very often people are reluctant to report, especially in the US, if there's any kind of law enforcement history involving that person, if there's a warrant out, or if there's been any kind of arrest or transgression in the past, even a minor drug offense, they don't want to report. There's the shame and the blame and the stigma can be overpowering. And importantly, the danger may actually increase after leaving. Okay, and that's when most of the domestic violence homicides occur, is when the perpetrator realizes that their partner is taking action or may be leaving. The danger increases dramatically at that point. It's the most dangerous point. And we need to make sure that we understand and that we tell patients that the health effects that they are experiencing may actually worsen after seeking help. Not forever. They will improve after, but because those of us who've been in a minor fender bender know that we can handle ourselves, and get somebody's insurance information and write down all the right stuff and take whatever the pictures. And as soon as we get home, our knees turn to jelly. Okay, the health effects may worsen after seeking help until you get yourself together. Oh, okay, let's try this. There we go. The language we use is incredibly important. We don't have time to do this today, and Dr. Katzman asked me beforehand how long do you usually take in speaking to these slides, and I said I can take anywhere from 15 minutes to a day and a half. And when I had a longer time, I did a workshop once, and I broke participants up into groups of 10, and groups on one side of the room, I gave them a word. I said, I'd like you to describe and define this word. And the word I gave them was victim. And to the participants on the other side of the room, small groups of 10, I said the same thing, but the word I gave them was survivor. Okay. No group knew what any other group's word was. Okay. And this is a compilation of the words that came back when people were asked to describe the word victim. Weak, fragile, ashamed, paranoid, needy, dependent, dead. You can see that it's a rich thesaurus of terms. Then I asked the people to report on the words that arose when they described the word survivor. And look at the difference. There's almost no overlap. Courageous, lucky, accomplished, progress, determined, abuses in the past. So the language we use when we speak with patients and clients and the image that we internalize about our patients and clients can change dramatically with the words that we're using. For that reason, I never say to somebody or ask, are you a victim of intimate partner violence? I ask them, how do they define themselves? And I try and use those words. So going beyond survivor, we need to focus on the patient as a person, not as a case, okay? An individual or a person experiencing, and there's a line there because it's fill in the blank, because we need to ask the person, what are they experiencing? We need to ask the patient about their experience, not try and interrogate and check off screening and criteria so that we can make a diagnosis. We need to listen. And when I teach communication skills, what I tell my students is the hardest thing to do, and my goal for this course for you, is to teach you how to shut up. Just listen. Be interested, be engaged, but listen, and the story will emerge. Respect patients' realities, okay? My last point on this is first-year medical students in Fife. I'm going to leave that for now and substitute that with a little story about an experience I had in El Salvador. I was there twice teaching, and once at the invitation of Global Affairs in Canada, which is the equivalent of the State Department, and the second time at the invitation of the government in El Salvador at the time. And I noticed that I tried to translate my own slides into Spanish because I thought my Spanish was good enough for that, and it was not. And they made some corrections on my slides. And every time I had the word patient, they substituted it in Spanish with the word person. And I said, why did they do that? That's not what I meant. And they said, because we are making an effort to actually teach everybody that the people who see us, who care, are personas, are people. Okay. And that's a government decision that they've made. I don't know if that's still in effect. So let's move along now and talk about obstacles to leaving. So we know that intimate partner violence is bad. We know it's actually quite prevalent. And I don't know if you'll notice here, I'm not putting prevalent slides, prevalent statistics into this talk, because it depends on how you ask, who you ask, and what your definitions are. I can tell you that intimate partner violence is enormously prevalent. I can tell you that at least 15 homicides in Connecticut were domestic violence related in 2023. I can tell you that homicide is only the tip of the iceberg. I can tell you that our community partners who do this incredible work every day and every night are deluged with calls and inquiries and requests for help. It is super common, okay? I'm not going to give you a number because there is no number that I rely upon as safe. So if it's so common and if it's so bad, why don't they just leave? Why do you stay? Why do you leave? Why don't you leave? Well, the top reason is fear. And very often a survivor will say, he said he will kill me if I leave. He said he will out me for my sexual preference. He will make sure I never see the kids again, and I don't know what he means by that. I will lose my job. I will lose my home. I will lose my permanent residency or my visa. Okay. There are lots of reasons that people are legitimately afraid and they stay because the devil they know is better than the fear that they don't know. Okay. They may actually have thought this through and have determined that there are no safe options, that they're stuck and that they need to make the best of it. They may feel like a failure. They may have been told you're a failure. The whole situation is so overwhelming. If I were to tell you, you had an hour to pack everything you wanted for yourself and your 3 children under age 5 and leave, how would you do that? You can't even pack a diaper bag in an hour and make sure there are snacks. It's overwhelming. You may not have the money. I had a patient once who saved in a secret buried jar nickels from redeeming cans until she had enough money for a one-way bus ticket to her sister. Okay, and it took 2 years. You may not have enough money to make it on your own. The perpetrator's behavior may be an influence on why it is so hard to leave. The perpetrator may say, "You leave, I will kill you," and it will be painful and slow. Or the perpetrator, after trying to leave, may have come back with tears and chocolates and flowers and on bended knee and say, "Please, please, I don't know what happened to me. I just lost it. It'll never happen again. You're the only thing I care about in this world." So the perpetrator's behavior may be a big influence on whether somebody leaves. Survivors are very often truly concerned for their partner's welfare and for their future, especially if they're from a minority community that's already being systemically oppressed. They don't want this person's life to be worse. And also, you're in love. The relationship didn't start out abusive, it started out quite loving. And you want to go back to that, okay? And that ties into the promises of change and the desire to help somebody change. Very often, you're isolated from your family or community, or they will say, "Go back and try harder." And some of the cultural and religious expectations and pressures are quite hard to overcome. In the work that I did with Reverend Miles back in the last century, one of the obstacles that we came up with were people felt that the greater Christians especially felt that the greater pain they endured in this life would lead to greater reward in the next life. I also worked with some South Asian immigrants, and they felt that in general, that whatever they were going through in their current life is a reflection on their worth in a private life, and that they needed to continue in order to get to a better life in the next life. So cultural and religious expectations can be really, really quite profound. And we don't know about those unless we ask, and unless we shut up and wait for the answer. So a lot of people ask, should I leave or should I stay? And most of the time we see that survivors may make a very deliberate choice to stay until they can leave safely, which is why I tell learners to never say you should leave or you need to go or why don't you leave, okay? They're there because they've made that choice, okay? Some people stay until a red line has been crossed. Leaving is not something you just say, okay, I'm out, I'm done. It's a monumental, life-changing, life-altering decision. And it's often the more dangerous choice, as we talked about before, and requires planning, especially when children are involved. So we need to ask our patients, tell me if you've thought about leaving. What made you stay? What made you think about leaving? What preparations have you done? The whole tell me more, and then shut up and wait for the answer. So here are some examples of people who stayed, and then a couple of when a red line was crossed and they left. Here's a quote. When I tried to get help, I was counseled to consider carefully how what I said might affect his career. And so I kept my mouth shut and I stayed. I was told, yes, he was deeply flawed, but then again, so was I. And so I worked on myself and I stayed. If he was a monster all the time, perhaps it would have been easier to leave. But he could be kind and sensitive, and so I stayed. He cried and apologized, and so I stayed. He offered to get help and even went to a few counseling sessions and therapy groups, and so I stayed. He belittled my intelligence and destroyed my confidence, and so I stayed. I felt ashamed and trapped, and I stayed. Friends and clergy didn't believe me, and so I stayed. I was pregnant, and so I stayed. I lost the pregnancy and became depressed, and so I stayed. Now, if you take this statement from this slide and the slide previous, that's basically my list of obstacles to leaving. This one quote encapsulates almost all of it. And that quote was made by Jenny Willoughby, who in 2017, and you can look her up, she's got a Substack, which is actually brilliant. She is the former wife now of the staff secretary to the former president. Okay, so this is a woman who was educated, who was well off, who came from privilege, basically. And she couldn't leave because of all of the reasons that we've discussed. But sometimes people make a decision and they say, that's it, I'm gone, I'm out. And these are all from Lawrence O'Donnell's show on MSNBC. He featured a segment with Jenny Willoughby and had and showed a bunch of tweets that people wrote in during his show and after. Here's one: I tried to be a better wife and I had babies and I thought maybe I deserved it. And I thought because it wasn't constant and there was no lasting damage. Then he did it in front of my son, who was 8. And so I left. Here's another one. The piece you read about Rob Porter's wife, that's the Jenny Willoughby's former husband, on why she stayed, sounds exactly like what happened to me while married to my first husband. Thank God my dad rescued me. I married a great guy the second time around. Here's another one. At 20, holding my infant daughter in my arms, he hit me in the mouth. She was covered in blood, in my blood. I looked at her and I said, over my dead body will I give her a life like this, left in the night and never looked back. So those are some examples, and there are thousands, tens of thousands of examples. And we will get our own examples when we ask our patients, tell me why you made the decision to stay. And then shut up and wait for the answer. And here are some other barriers to why it's so hard for people to disclose to us. And we need to keep these in mind, especially when somebody denies or fails to disclose what's happening with them. It's not because they're lying to us. It's because they're making a decision that they need to make at that point for their lives. Fear, all the reasons we discussed before. Perceptions of the healthcare system. If the healthcare system has photographs, if the waiting room in the office has photographs of happy mothers and happy babies that are not of your race or culture and not of your life experience, you're going to feel this healthcare system doesn't get me, doesn't understand what's going on with me. And we all know that all healthcare is now far less personal than it used to be. It's far more mechanized and digitized. And you may think that the healthcare system is just it's gonna get swallowed up somewhere and then visible to everybody. And I'll speak a little bit about documentation in the electronic record and actually how safe that is in a little bit. People are afraid of Child Protective Services referral. And that's why we need to communicate confidentiality and its limits, honestly, before we speak to patients about this. They may not disclose unless they realize that they're going to be safe and that you're on their side. They may be afraid that they're going to lose their health insurance and lose their health care if they disclose to you. Their language and their culture and religion may be a barrier as well. And I'll just segue to a small story about my daughter, who is a fairly well-known cartoonist. She's trilingual. She speaks English, French, and Spanish fluently. She's actually married to a guy from Argentina, and he's trilingual also. Her native language is English. His native language is Spanish. They both can get along perfectly well in any English or Spanish speaking country, but each of them has said to me independently that in the second language, the one they learned, not the one they were born and speaking natively, they can say anything they want, but they only have one way to say it. In their native language, they can say it 6 different ways. And also my daughter also shared that even though she can talk about what happened if she needed to, she could not communicate the nuances of emotion that she was feeling in another language. So even if somebody is fairly fluent, their own second language barriers, even if it's not apparent in everyday life, might actually be a barrier to disclosure. We talked about culture and religion. We talked about stigma and shame, and immigration status is a huge issue in the US, less so in Canada. But that is an amazingly enormous issue, and it's got an asterisk because it's got a slide coming up. Also, legal concerns that we spoke to a little bit earlier, as well as sexual orientation and gender identity. And finally, we can always remember abuser threats and control as a major, major barrier. If you tell that doctor anything, or if you say anything, I don't even have to tell you what's going to happen. And that's not even a threat. Like, legally, that's not even a threat, but it's life-changing. So here are some concerns about undocumented migrants. Very often there's a lack of knowledge and misinformation about the legal system in the US. And some of that misinformation is paralyzing, actually. There's a tremendous fear of arrest and maltreatment and deportation, even among those who are here legally, okay? But dramatically increased for those who are undocumented. Authority figures are figures to fear, not figures to seek, if you are undocumented. You may fear being separated from children, and all you have to do is understand what's happened in the last few years and how many children are still separated from their parents. The language and cultural barriers we spoke to. You will lose connections with family and community here in your home country, and also financial survival. How will you get along? How will you eat? So those are lots and lots of barriers to disclosure. It's like, you may as well pack it up now and not even bother. No, there's a lot we can do. Okay. But we have our own challenges to overcome. And those are both personal and systemic. In terms of personal challenges, this is a hard topic. This is hard to understand, and it's uncomfortable. It's so common, every one of us knows somebody, if it's not ourselves, and thank goodness it's not myself. I'm blessed to do this work without coming from personal experience, but I'm very, very aware that I'm quite privileged in that regard, okay? But it's uncomfortable for so many people. A lot of physicians especially have never learned about this. I certainly didn't. Anne Flitcraft has been my inspiration all these decades. I don't know how much you know that, Anne. I know you're on this webinar, but most people have never learned about it. It's like, I don't know anything about this. And so they're unsure what to do. They don't know how to inquire. They don't know how to respond. And what if somebody says yes? This has been said to me dozens of times. What if a patient says yes? I wouldn't know what to do. A lot of us, all of us actually have unexamined cultural bias and insensitivity. And we need to all recognize that and work on that in a dynamic way throughout our careers. And a lot of people say, well, that's somebody else's job. That's the social work job, or that the nurse can do that. Or there's a poster in my waiting room and you know, that's sufficient. It's our job. And we, in terms of are a team. And so, yes, it might not be you doing the asking. It might be your medical assistant, the nurse that works with you, your advanced practice provider. But the term you, as it's your job, is your team, and you are part of the team. So it is all of our job. In terms of systemic challenges, this is true. There's no time for this. There's no time for anything anymore. My old chief of medicine once said to me, when I was complaining that I didn't have enough time to churn out 3 or 4 more publications a year to get myself promoted, he took his glasses and he readjusted them and he put his paper down and he sat back and looked at me and he said, Elaine, when something's a priority, you make time for it. There is time. We need to manage our time better. Very often there's not a private or confidential space. That's a huge issue. So we need to figure out how to create that somewhere in our office space so that somebody can ask somebody alone, okay? It's not normative. It is normal, okay? But it's not normative. Intimate partner violence is not often in the differential. So I find that my medical students always know more about this than their residents and attendings, always. And so it's important for them to bring it up when you're talking about somebody with rib pain. Well, what about assault from a partner, perhaps? Okay, they're the ones pushing the envelope, and I'm very, very proud of that, because in Canada, it's much more hierarchical medical education. And so I'm trying to have our students be more assertive and actually be leaders in this field. Most of us are really unacquainted with our local resources. And I'm going to bust that one up a little bit later today here, okay? There are not that many role models. Like I said, Anne was my role model. That was it in terms of MD. There was nobody else back then. So we learned from advocates, we learned from social workers, we learned from detectives, we learned from survivors. So your role models are not just people with your training and then some. Your role models become the whole society, okay? And in Canada, because I know we have participants in Canada, the Canadian Task Force recommendations are not helpful. They're 10 years old, and they are different from the US Task Force, Preventive Services Task Force recommendations. We need to change that. So I invite my Canadian colleagues to work with me, and we'll see what we can do. So let's talk a little bit about survivor dynamics before we get to the clinical aspect of this. Just as a summary, survivors are in fear in one level or another most of the time. They can't sleep. I don't know any survivor who sleeps through the night soundly. Okay? Most survivors feel they're walking on eggshells. They're always navigating a changing landscape where the rules keep changing and you don't know you've gone over the line until you get punished for it. Okay? Their independence gets eroded. Their world keeps getting smaller and smaller and smaller. And many of them honestly, sincerely, genuinely want to improve the relationship, not end it. They feel like they're the ones who have failed. And their bodies respond with chronic and recurrent health issues. And that's where we come in. For perpetrators, the partner is often seen as an inferior, unworthy, less than poor person who needs to be kept in line. The purpose of the coercive behavior, except for the small minority who are real malignant sociopaths, is to assert and maintain control, to keep this relationship together, okay? They think they're doing the right thing. It's the way they grew up. It's what they see on TV. It's what society supports, and they think there's nothing wrong. In court or in other public or administrative settings, the abuser may appear better put together, more believable, healthier than the survivor. The survivor who's sleep deprived, whose life is in disarray, and who's afraid, is not going to appear as relaxed and well put together as an abuser. So in summary, this is not an accident. This is not about anger. This is not about loss of control. This is about power and control. It's about coercive control. As a matter of fact, Anne Flitcraft and her partner, Evan Stark, have published a book with that title, Coercive Control. Look it up. It's a great book. This is about intimidation and fear. This is not an accident. This is not a problem of loss of control. It's not an impulse control disorder. And this is not about anger, which is why anger management does not work, okay? And it's not a problem with the relationship. So those of us who do couples counseling need to be super careful about this. And we'll talk about that a little bit later. And it's not the survivor's fault. Now, I will admit that most relationships are pretty complicated. And there very often is toxicity in the relationship, which in this society comes across with abuse and violence very often. So it's not always one person is 100% wrong and the other person is 0% wrong. But there is usually one person whose life is getting smaller, whose life is getting more dangerous, whose life is getting more isolated. And that's how we look at this, not about who's right and who's wrong. So with that, let's take a deep breath and talk about clinical practice. I'm keeping my eye on the time, so we have lots of time for a discussion afterwards. In terms of physical health presentation, for those of us who do clinical care in the physical realm, and for those of us who are therapists and who understand that patients see their physical clinicians for these things, this is basically what we see in our normal morning of practice: back pain, other musculoskeletal complaints, headaches, abdominal pain, pelvic pain, recurrent sexually transmitted infections, eating disorders, medical issues that just aren't well controlled, diabetes that's never in good control, hypertension that's never in good control. And we think, oh, that's a non-compliant patient. Well, maybe it's somebody who's so super stressed that even the best care can't control that disease. Maybe it's somebody who has a partner who takes their medications away as punishment and doles back half doses as rewards for good behavior. It may have nothing to do with their own interest in their own healthcare. We see a lot of people with chronic sequelae of injury, pain syndromes, scars, physical limitations from prior injury. And medical clinicians see a lot of patients with somatization disorders. One of the hardest things that I have done in my career, and I know that this is commonly shared among other people at my career as a general internist, is when somebody came in with a somatization disorder, your urge is to say, you're fine, come back in 6 months or a year. Where what we know now is we have to say, I understand this, that you might be going through some hard times. I want to keep an eye on this. Can you come back in 4 weeks? I want to see you every 4 weeks so we can keep tabs on how this is going. And guess what? At the bottom, acute injury. Just like physical attacks in terms of the spectrum was at the bottom, acute injury is far less common than all of these other findings that we see. In terms of mental health presentations, these used to be thought of as pathologies, and we would bill for them, and we would be paid for that. But now these are reconceptualized as adaptations, expected adaptations to toxic stress from coercive control. Sleep disturbances, as I mentioned before, substance use, including alcohol and other substances, chronic pain and somatization, anxiety and panic disorders, depression, post-traumatic stress disorder, and I put post in quotes because it really is traumatic stress disorder if it's ongoing, and much of it is. Hypervigilance. I've seen so many times that when I'm taking a blood pressure or doing something with a patient and a door slams outside, my patient will jump. Hypervigilant, they're always on yellow, if not red alert. A lot of dissociation because you just can't be in that personality. It's too painful. You need to be in a different one. And suicidal ideation, suicidal behavior is very, very common. I also see self-harm without suicide, cutting, trichotillomania, things like that, and because at least you can have some control over that. And I also want to add in obesity, morbid obesity to this. And morbid obesity, if you know about the adverse childhood experiences study, which if I had another hour, we would talk about there, that was the entry point to that whole field of expertise about ACEs. So look up Vince Felitti, F-E-L-L-I-T-I, adverse childhood experiences study, and you'll probably be able to find the origin story of that whole field of care. So let's add morbid obesity into both the physical and the mental health. So looking at clinical evaluation, I want to talk briefly about taking a history, physical exam, documentation, and risk assessment, all of this done using principles of trauma-informed care within a resilience rather than a pathology framework. I think we all know the resilience framework in this audience, but just as a quick recap, it's patient-centered. It comes from the patient's perspective, not from ours. It focuses on strengths and attributes that the patient may have or abilities rather than weaknesses or problems that they're facing. It focuses on where are you now and where would you like to be in the future rather than focusing on the past. So it's more of a vision or a purpose focus rather than a problem focus. And it's a focus on how to help somebody make safe and independent decisions for the future that they define, not on what went wrong in the past. Trauma-informed care, I'm going to skip over this or just attend to it very briefly. I conceptualize it as universal precautions about lifespan trauma. Just like we always put on gloves now, we didn't used to, but we always put on gloves when we do any kind of procedure because you don't know, you can't tell who has a transmissible disease that you might catch. Same thing in terms of lifespan trauma. It is so common. It is more than 50% of everybody. Okay, so we need to practice in a way that we assume that that's happening or that has happened with each patient. Okay, beyond trauma-informed care for the individual patient, we need to start thinking about how to create and evaluate trauma-informed systems, both for our practice settings and for the entire healthcare delivery system. Okay. And the details of what to do with trauma-informed care are included in this slide. I just want to move past it, excuse me, not to diminish its importance, but just in the interest of time. But just to note the last point, what a survivor chooses to share does change over time. So we don't need to ask and get the whole story. We need to make a safe space so that our patient, client, survivor, persona will share what they feel comfortable sharing. Okay, and here are some tips on trauma-informed care about how can you do that in an individual setting. The bottom says promote safeness as well as safety. Safeness is a concept that was originated by a dear colleague, Connie Mitchell, who's now the director of maternal and child health for the state of California. And she came into this work through her work as an emergency physician. And what she describes as safeness is an internal sense of feeling safe in yourself and in your surroundings, whereas safety is more external. How can I make this parking lot safe? How can I make this waiting room safe? Those are external things that we can do. Safeness is what a patient or client will feel when we have done our job. In terms of how do we ask? And I want to make note that I'm saying principles of inquiry and care. Not once in this presentation have I used the word screening. This was probably my biggest career regret, that I wasn't forceful enough when we were first doing this work in the late 1980s and early 1990s to say this is not screening that we're talking about. This is inquiry. Inquiry is a conversation. Screening is a thing that you check off. And I wish that I were more effective back then, because I think that might have made a difference. But principles of inquiry and care always keep safety in the forefront. That's the most important thing, is what I'm doing, is what I'm asking, is how I'm setting up my waiting room, is what's on the tablet that I give the patient to fill out a questionnaire when I don't know who's sitting next to them. Is that going to help my patient be safer, or at least not put that patient in additional harm? We not only have to think about the patient, but about the patient's children and other dependents, about our own staff, and about ourselves. Okay, so safety has to come first. We need to inquire routinely, not just about what's happening right now, but about traumatic experiences across the lifespan. Okay? We need to be trauma sensitive, and we need to be active, engaged listeners. And listeners means stop talking. Okay, it means listen. And it means waiting that painful 7 seconds with an engaged body language to let the patient formulate what they want to say, decide if they want to say it, and learn from our patients is how has this affected you? Okay? And avoiding judgment, of course. We also need to say thank you. Thank you so much for sharing that with me. Okay? Validate the patient by acknowledging their courage and resilience. They may not have ever thought of themselves as courageous or even worthy. Respect the patient's decisions. Don't try and convince them to do something they may not be ready for. And please, we are not there to rescue our patients. We are there to be a safe space, to be a place where a patient can generate safeness, a feeling of safeness around us and around our whole healthcare system. Be honest about the limitations of confidentiality, not just that you will keep this confidential, but what your reporting obligations are. You can do incredible harm if you say to a patient, well, now that you've shared this with me, I have to tell you I'm a mandated reporter, and so I will need to file a report. Okay, that patient will never tell you anything again. That patient will never tell anybody else anything again. That patient will tell everybody they know that you cannot trust this healthcare system. Do not say anything. Okay, so one little mistake like that will cost down the road in ways that we can't even comprehend. So say, if you tell me something that I feel it tells me that a child or dependent of yours is in danger, is being harmed, or that you're going to do something that's going to harm somebody else, I'm legally required to report. I will do that as your ally so that you can get the help that you need. But I do have legal limitations. You do need to know that, okay? And if a patient makes a decision that they're not going to disclose to you at that point, that's okay. They may come back, they may have that doorknob phenomenon where they are on their way out and say, can I just talk to you about one more thing? Or they may come back again, or they may come to somebody else and say, you know, I really do want to talk about this, okay? And always take care of yourself. You cannot let this work consume you. Just like in the airplane when they say if the oxygen drops down, use it for yourself first, place your own mask on first before you assist somebody else. You can't do this work unless you take care of yourself. So inquiry is an intervention. It's more than screening. Oh, I did use the word screening on a slide. There it is, okay. The active inquiry can be life-changing. It begins the process of integration. Remember, I'm not talking about healing. I'm talking about integrating the trauma and using that to be able to move forward. Every time you inquire about abuse, you are actually changing somebody's world. Everybody I know that I've spoken to, and I've asked about this a lot, if I ask, have you ever been asked about violence or abuse by a healthcare provider? I will get yes or no. I will not ever get, I don't remember, unless it's somebody with a memory issue. It's a really phenomenally powerful event in your interaction with the patient. Just the act of asking is an intervention. It's huge for a patient. It's not just a thing. It's enormous, okay? So when should we inquire? Well, certainly when there are physical cues, when there are social cues, but most importantly, even when there are no cues. I coined this term back in 1992. Now everybody's got an acronym for everything. But this one seemed to make sense at the time. Use your radar. Remember to ask directly, document your findings, assess for safety, review options, and refer. So that's the radar. And then there's an F of follow up. Because if you don't follow up, the message the patient gets is, thank you for sharing this with me, please go away. But if you say, I would like to touch base with you again about this, if that's okay with you, that conveys a message of, I care about you. That's really powerful. But we couldn't coin radar. We couldn't say, use your radar. So use your radar. And here are some tips that you can use to create a climate for inquiry so it doesn't just come out of the blue. Wear a button, put up a poster, put tear-off cards in your washrooms. And those, by the way, have to be replenished very, very frequently. It's amazing how they are taken so quickly. And I would like to ask our local partners if they can generate a QR code if they're producing the cards for practices, and if there can be a QR code on the card, because then they don't even have to tear off the card. They can just scan the QR code. Put articles in newsletters. Make public service announcements. That's community-based efforts. Put an article in your local newspaper. Be part of a community council. Excuse me. It will be, I remember I was one of two physicians on, two healthcare providers on the Massachusetts Governor's Commission on Domestic Violence. And I dared not move during meetings, because if I moved, if I did this to my hair, or if I took a tissue and rubbed the governor, who was the chair, would always think that I wanted to say something. It says, oh, the doctor has something to say. And it's, everything we say carries so much respect, and we need to use that for good, okay? And also set aside and manage your staff time for responsibilities and coping. 15 minutes at the end of the week or at the beginning of the week. How you doing? What have you seen that's been difficult? What can we do to help each other? Okay. So part of this is your individual stuff with patients, but part of it is how do you manage a practice? And then you might want to frame a question to your patient before just coming out with a question. You want to say, and anytime you see a check mark, it's something that you can say. You can certainly adapt it to your own voice and practice style. But I usually say something like, so many patients I see are coping with abuse in a relationship or have had difficult experiences when they were younger. So I've now started asking all of my patients about bad or frightening experiences they may have had as a child or as an adult. Frame it in whatever way you want. Here are two examples. Okay, the first one also includes naming child abuse, sexual assault, and other things. Whatever you want to do, just take these words, make them yours, change them the way you see fit. But it's always important just to have a little bit of a framing statement. And then ask directly about what has happened. Has anybody ever threatened, frightened, or hurt you in any way? Has ever anybody touched you in a sexual way or made you do something sexual when you didn't want them to at any time in your life, including when you were a child? Most patients have never been asked this. Never, ever, ever. And you can change their life by asking one question. And ask it in a way that's earnest. Ask it in a way that shuts up and listens for an answer. You can also ask indirectly. You can say, every family, every couple has conflict. What's it like when you and your partner or family disagree? Or I've seen people who've been hurt or threatened by someone they love. Has anything like this ever happened to you? Do you feel safe at home with your partner? Or the bottom one, which I put in bold because I think it's so useful. If there was one thing you could change in your relationship, what would that be? And you may get an answer like, teach them how to do the dishes or pack the dishwasher. That I could say. You might hear, I just wish he he wasn't so jealous. And then you say, tell me more about that. What do you mean by that? Give me an example. Help me understand whatever it is that you use to encourage additional dialogue. So these are all good ways to kind of make the climate right for inquiry and make inquiry into your own voice. Then if you want to put something in a written question, go ahead. Here are some examples, okay? And if you use any of these, please make sure that you're asking them in a way that is safe, that they're not sitting in the waiting room, potentially with an abuser next to them, who's going to watch what they say or direct what they answer. Also make sure, especially with our conversation about language that we had before, that it's a question that can be easily answered. I also want to add to language literacy. I had a patient once who was the daughter of a sharecropper, actually, from the South. And she brought in a jury duty statement for me to sign saying she couldn't do jury duty. And so I looked at it and I said, well, actually, right here, you have to sign. This is the place where you sign. And she asked, could I read it to her? And I assumed that it was because she had diabetes and her eyes weren't so great. And I said, is it hard for you to read? And she started crying. And I didn't realize after taking care of her for several years that she could not read. She was illiterate. She never had any education. So sometimes we can ask questions like this that we think are clear, that we're asking in a safe setting if we have the patient alone when they're answering, but they can't read. So be careful with that. The other thing is that adults, older people, very often don't want to put anything in writing. They'll talk to you face to face. You can ask them, they will be honest, forthright, but they don't want it in writing. And adolescents won't talk, but they will answer all kinds of questionnaires. It's really an age gap that's quite incredible. So please keep in mind that just putting something in a written questionnaire that you're asking what their allergies are, what medications they're on, and all of this, that's not enough. We need to understand each patient individually. So if abuse is suspected, ask direct and indirect questions to the extent that you feel comfortable, and then ask additional focused questions. Especially if you ask a question and you get an answer like, my husband loves me, and they look down and they don't answer the question, it actually means yes. Okay. But you don't want to say, aha, I see that you've answered yes. So you can say something like, when I see someone with an illness or condition or injury, it like I'm seeing here, it's sometimes because someone has hurt them. Has someone hurt you? Tell me what happened. And remember, they may not feel comfortable answering you at that point, and respect that. So here's a 2-minute triage, which is now actually a 1-minute triage if you just want to ask the yellow questions. Tell me what happened. Was a weapon involved? Are you in danger now? Do you need help from the police or from anybody else right now? Okay. If you have a 2nd minute, you can ask about the person who hurt you. Have you tried to leave? Tell me what happened. Have your children ever seen you being hurt? Have your children ever been threatened? And you could preface that by, I want to ask you this with the understanding of my limits and confidentiality. But that 2-minute triage will help you figure out whether you have a 5-alarm danger right now, or whether this is something that you can say, thank you so much for sharing this. This is super important. Can we meet again in the near future so that we can really do a deep dive in this and figure out what you need in terms of help from us? Okay, so that's your 2-minute triage. Here are some follow-up questions. There's a ton of them. I'm not going to read them all. You can read much better than I can speak, but just ask the history. And again, anytime you see a check mark is something you can ask and adapt it to your own voice, okay? But you're asking about what happened, about the most recent time, about insults, blame, You can be asking about social isolation. Can you speak to your family or your friends? Can you come and go? Tell me what things were like when they were good, and tell me what happened when things started to turn. Okay, so there's a lot of follow-up questions you can ask. You don't need to ask them all, and you don't need to ask any of them unless they feel right to you with your patient or client in that situation. Here are some more follow-up questions that have more specifically to do with mental health and suicide and self-harm. And the bottom one that I put in bold on purpose is, who in your life can you trust or confide in? Because we always need to ask, who are your supports and what are your resources? In terms of physical exam, I'm going to do this quite quickly because I know most of us are not physical practitioners, but this is what we do. We look for any injury, bilateral multiple injuries, a delay between the injury and the presentation, explanations that just don't seem to make sense, and if the prior use of emergency services have been accessed. We look for chronic pain, any sign of psychological distress, any pregnant person with any injury, or any partner who is protective or refuses to leave. In terms of documentation, we need to do it because it's medically the right thing to do. It's morally the right thing to do. It actually may keep you out of court in a criminal or custody case or in a standard of care case, because there have been some cases with that. And to my hosts, I'm well aware of the time, just to let you know. In terms of documentations, you can use written descriptions, diagrams, or sketches like this. And you could put areas of pain in there. And these slides are not in your slide deck that you have out of respect for this person. She is a colleague. These pictures were taken a long time ago. She's not wearing vintage clothing. This was in style at the time. This shows a picture of this patient with this injury at this date. The white piece of paper has the date written on it. Here's a close-up of that. And by the way, those of us who are in medical practice know that that's just a ecchymosis. It's superficial. It's going to heal. There's really no problem with it. It's very, very, very effective in court. This is a picture of an abrasion on her chin, which demonstrates multiple injuries at the same time in different locations. Here is a picture of her with defensive injuries on her forearm, trying to protect her face. And here's a picture of this woman who is an academic pediatric dentist with her then husband, who was a lawyer. He's no longer a lawyer. And they were at a cocktail party at the home of the very famous judge that he was clerking for at the time. And you can see that both of them have black eyes, that she's in a different dress. Her black eye was not present on that other assault. So this is a different assault. He has black eyes to protect me, by the way, because I did not want him identified. By the way, he did not allow her to wear red because he thought that that would mean she was flirting with other men. She could only wear blue. In terms of follow-up, it's important to figure out who's at greatest risk. You can do an appraisal. The patient appraisal is important. The risk factors are an increase in the frequency or severity of the abuse, threats of homicide or suicide by the partner, whether a gun is available or has been used or brandished, whether the abuser knows of the survivor's plan to leave. There we go. Your role is to communicate concern and assure confidentiality with its limits, to provide information that's vital, to review options and make referrals, and to connect with community-based advocates for safety planning, support groups, shelter if needed, legal advocacy, and to collaborate. And yes, the medical treatment and follow-up, you can do that too. Less important, okay? Here are some of the things you can do to communicate concern. And I'm not going to read these all, but you need to validate the patient and convey empathy in whatever way feels right to you. But these statements are so impactful. You can express concern. Just say, I care about your safety. I care about you. And leave the door open. You have choices as your situation changes. My office, our community agency will assist with information and support. And to say, you're always welcome here. We respect you. Assure the confidentiality. Again and again and again. We talked about that. Provide information. Say, what's happening is not uncommon and it's not your fault. Just to tell them what happens, it can increase. Your symptoms may get better once you're safe, but they might temporarily worsen, okay? That children can be affected. Offer resource referrals for safety planning, for support groups, legal services, social welfare. There's all kinds of resource referrals that will help end that person's isolation. Here are some key resources. The first one is your local domestic violence crisis center that serves 7 communities in the local area that are listed there. That's their website. That link works, but I dare not use it because I don't want to disrupt my slide share right now. But the link is active, and I believe it's active on your PDF as well. And they have a 24/7 hotline and an array of tremendous services. And their COO and CEO are part of this webinar right now. So you can ask them any questions or lodge any complaints about it that you want. There's also a statewide coalition, the Connecticut Coalition Against Domestic Violence, the National Domestic Violence Hotline for those who are in the US, but not in Connecticut, and the National Sexual Assault Hotline. For those in Canada or in other countries, I'd be happy to connect with you separately about resources. In terms of safety planning, this is really important, and it's not something we should be doing. This is something advocates do best. Those are our consults. It's like when you have a patient with a heart problem and you send them to a cardiologist because they know more, our advocates know more, and our local crisis center knows a lot more. That safety planning is a process. It's not a handout. It's not a thing. It's not static. It involves the survivor and really speaks to what they need right then and there, okay? And please connect with your local resource agency for that. Components include a disaster plan. What happens if things get really bad? What should you put in a grab and go bag? Where can you hide it? Where can you go? How can you get there? People need to game out these situations, okay? And each situation is different. What do you do if you stay and the abuser leaves? If both of you stay, and that happens most of the time, and what happens when you leave? What do you need to plan for? We talked about follow-up before, and that really lends support and credibility for the survivor. It helps you manage yourself and staff in terms of your time and schedule. It strengthens the relationship because it does convey the message of I care about you. You get better at it because you learn more. You get energy from working as part of a team, and it does get easier over time. So here's the summary, your role as radar. And we talked about all of these components, I believe. And please don't forget that you have a public advocacy role as well. As a healthcare provider, you are respected in your community. You are valued as a team member. Remember the story I told you about the governor and how I dared not even scratch my nose. You are a change agent in your community, and you can help prevent. You can be an innovator in prevention efforts. And there are lots of opportunities for leadership and scholarship. And I'm going to skip over that and just get to my last slide, which says thank you. And I will be happy to answer questions in the next 10 minutes and also for the next 50 years, I hope.
Dr. Alford, thank you for such a brilliant, comprehensive, thoughtful, and emotionally attuned presentation. Just brilliant. And I know we won't be able to get to all the questions that continue to roll in it, but all of the information you presented was so so critical. So thank you so much. And I just want to let you know that many of the comments coming in have to do with an acknowledgement of you and what you presented to us today. I want to just give a shout out to Dr. Emily Haas out there, who writes in, Dr. Alpert, as the trauma psychiatrist here at Silver Hill, your talk is directly related to what I and my team do every day. This is an absolutely beautiful talk, and I especially appreciate your emphasis on the importance of safety in assessing and treating survivors and on the importance of language. Thanks for this marvelous talk. Yes, and for everyone out there, I had asked Dr. Alpert, is it okay if we don't get to your question to go ahead and contact you? And you, that's why you said you've provided your email. So I'll just get through a couple questions. I had one first that you triggered in my mind. In your experience working with patients kind of in primary care who would arrive with a significant other to the office, do you always make time to talk to them alone, or how do you kind of deal with that situation?
That's such a good question. So prevention is the best treatment first. And so we know, we've all been to an airport, and we know that there's a sign there that says ticketed passengers beyond this point only. Okay. And if you're not ticketed, you can't get beyond this point, so that you can make sure that patients stay in the that visitors stay in the waiting room by having such a sign. And if somebody tries to come forward, just say, you know what? I wish we could, but only patients are allowed beyond this point. Now, let's say that person muscles their way through and gets in. There are other tricks that you can use. You can, if they're in the room with the patient and you really need to ask them something and get them out of there, you can have a sign, if you're working with your team, you can say, do you mind stepping outside, because there's a billing question that we have to address with you. And, or you can say to your patient, I think we need to do a clean catch urine. You can't do that if you're in psych therapy, in a therapeutic practice, but in medical practice, we say, we'd like to do a clean catch urine. So why don't you come with us to the bathroom? And if the other person starts coming, say, we're going to the bathroom, we'll be right back. Why don't you just stay here? And you can also say, you've had a cough. I think we need to do a chest X-ray. And if the person starts coming, say, you don't want to go there, go on out of radiation. There are tricks that you can use in each practice. Work out with your team. What do we do if we need to get somebody out of there? Okay. You can have a sign. What we did in my practice is I would say to the medical assistant, do you remember where that magenta flyer about exercise and health is? I want to get my hands on that. And that would be our code word, that I need somebody to ask this person and get them alone. And we would be able to, while that person comes back with whatever the magenta flyer is, I would say to the potential abuser, do you mind stepping out with me for a minute? I want to kind of ask you something in private. And then that person would come out because they thought they were really important. And I would say, talk to me about how much she exercises or whatever it is. I would make it up. While the medical assistant with the magenta flyer would be asking about domestic violence. There's lots of ways you can do this, but you got to be creative with your staff.
Yeah. So a shout out to Bettina Bernstein out there, who says, Dr. Alpert, thank you for one of the best talks I have ever heard. And I know that Bettina attends a lot of our programs. So thank you, Bettina, for that. And ask a really, really critical question here. Do you have any tips regarding telehealth and domestic violence screening?
Yeah, actually, a group of my students, so Bettina, write to me and anybody else, a group of my students during the pandemic got together and researched this and created a fabulous publication. It's geared towards Canada, but it gives stepwise, if you suspect something and how to get the patient to give a sign for help if they need help. And this is the sign. You put in your thumb and you curl down your fingers, and that means help. I need help. And there's a whole bunch of other recommendations that they have. I'm happy to share their publication.
Great.
But yes, you do want to ask somebody, can they put headphones on? Can they talk with headphones so that only they are hearing you speak? Can you ask them, is this a time that you can be by yourself? You know, because kids are around and other people. That publication will help address that. Great
That's
question.
great. Many questions here about what you alluded to in terms of kind of interactions with the legal system and reporting. And this person writes in, "Dear Dr. Alpert, are you able to elaborate on the dilemma of duty to report? For example, a patient comes in and tells you he or she has been physically abused by their spouse. It's happened repeatedly. I've seen that these things have been reported, which then unleashed a very counterproductive series of events. Patients lose a sense of control. Police come into the scene and so forth. Safeness goes out the window. It is not helpful."
Yep.
Are we at a point here that the legal issue needs to be reconsidered and thoughts about it in a more nuanced way? And I know you told us about kind of being honest right at the beginning. Do you have any further thoughts about kind of our relationship with reporting and the cascade of events?
We have to be genuine with our patients. We have to be honest, because if we're honest, we can potentially earn patients' trust. If we're not honest, we don't have a prayer in hell to do that. The other thing is that I want to bust that one up. We actually have a duty not to report. Okay. There are a few states in the country that require reporting if there is domestic violence, but most of them are reporting anonymously to police. And just in whatever state you are or province, if you're in Canada, check what your local reporting requirements are. I would rather not get a disclosure and allow a patient to decide when they want to disclose to us. But you can't report in most states unless the patient wants you to, or unless there's a child in danger or an immediate threat of a violent event, a lethal violent event against somebody else, because that breaks HIPAA. You're not allowed to do it.
Right. Can you say something? There are questions here about the differences between survivors who are men and women and perpetrators, both within same-sex and different sex relationships. Do you have any just kind of information about that?
There are some agencies who work specifically or in specialty with people in same-sex relationships, and you will see the same dynamics. That doesn't have anything to do with sex or gender. It has to do with whose world is getting larger and whose world is getting smaller. Okay, that's why this is not, I don't call it gender-based violence. I call it power-based violence. This is not about gender at all. And there are cases where there's a heterosexual relationship where the woman is the abuser. It's quite rare, but the prevalence of violence in US society especially is unnervingly high. And there's a lot of violence, and we need to think through ways that we can use our expertise to help prevent violence and coercion in the first place. A lot of that comes with teaching about healthy relationships in school, talking to young couples and parents about what their goals are and how are they going to solve issues and problems. This far beyond the scope of our talk, and let's do another one. I'm not the expert on that. Don't invite me. I want to attend.
You got it. You got it. Last question for you. If after reporting abuse, your patient quits treatment with you, do you ever reach out to them after they've just stopped treatment?
If you're in a counseling relationship and the patient has terminated,
Yeah.
we need to respect that. I'm not the expert in that. I would ask you if once a patient has actually terminated, but if they just stop coming, if they miss an appointment or two and they don't stop and they don't make another one, I would have somebody from my office reach out and say, wondering if you want to make another appointment. Doctor was asking you know, are you interested in making an appointment? We haven't seen you since whenever, but not go after them in any way about whatever they have disclosed or chosen not to disclose. Just say, I'm here to help. That's the main thing.
Great. Dr. Alpert, thank you so much. I've been looking forward to this talk for maybe a year now. So
We planned it a while ago. Yeah.
so
Thank
great.
you. Thank you. And I'm sorry I couldn't see anybody's faces during this talk because, you know, there's great opportunity doing this in a virtual webinar format, but the limitations are you're alone and with your laptop. And so I look forward to ongoing dialogue. Thank you.
Yes, maybe we can have you out for a in-person workshop at Silver Hill. That would be fantastic. So thank you for the presentation, and to all of you for joining us. Reminding you, for those that wish to receive continuing education credits, just complete the evaluation survey that will automatically show in the browser as we end the webinar. And I hope you can join us again on February 14th. But for now, we say goodbye, and thank you again to everybody for joining us, to you, Dr. Alpert, and this is goodbye. So great to see you, and
Bye.
see you all soon. Bye-bye.